I am Akriti Anand, and today we have the privilege to meet and speak with renowned cardiologist Dr. Harish G Mehta. He is the Director Cardiology at S.L. Raheja Hospitals of Fortis Associate. With over 25 years of rich experience, Dr. Mehta is known for building strong doctor-patient relationships and provide treatments that meets the patient's requirement. In today's episode, we will explore latest advancement in cardiology, debunk myths related to heart health, and provide practical tips on how you can maintain a healthy heart. Without further ado, let's talk to Dr. Mehta and find out what are the latest advancements in the heart health. Hello, Dr. Mehta, how are you?
Good, how are you doing?
I'm great, it's a pleasure to meet you, doctor.
Sure.
First of all, tell me, what is intervascular cardiology and what are the latest advancements in it?
So, interventional cardiology is invasive cardiology, where we provide alternatives to surgical options for heart diseases, which includes treatment for coronary artery disease or blocks in the heart, or even for valve diseases or holes in the heart, or electric disturbances of the heart. So, all these are covered under interventional cardiology. So I would want to know, what would you want to know today?
I want to know about valve diseases.
Oh, so you're talking about valve diseases?
Yes.
Well, valve has become the flavor of the season nowadays. Everybody's talking about valve disease. And valve diseases have been there since time immemorial. And India is a rheumatic heart disease capital of the world. So we have the maximum valve disease in the world. So what are valves? So I can show you on the model what are valves.
Yes.
If you see this model, valves are tissue structures like these that connect two chambers of the heart. And the function of this valve, as you see, is allows blood in one direction and prevents the blood going into another direction.
Yes.
So there are 4 valves in the body, 2 on the left, 2 on the right, one between the higher chamber and the lower chamber, which is left atrium and left ventricle, is the mitral valve.
Mitral valve.
Then the other one between the right atrium and the right ventricle is the tricuspid valves. Tricuspid, mitral. Then from the left ventricle comes the aorta, the biggest artery of the body which supplies blood to all the organs. There comes the aortic valve here. And from the right ventricle comes the impure blood which goes into this blue artery. Can you see this here? That's the pulmonary artery. This goes and gives the impure blood to the lungs. And from there, the whole heart circulates all around. So these valves normally should be functioning throughout your life. But unfortunately, it doesn't happen. Some of these valves gets narrowed. So we need to have options to treat these valve diseases.
Why do the valves become narrow?
Okay. So the valves become narrow due to multiple causes. In our country, the commonest cause, as I told you, is rheumatic fever, which happens in childhood where you get sore throat, and we think it's a minor sore throat, but that can affect the valves, which comes at the age of 20s and 30s. Then sometimes in older ages like 50s, 60s, the valve gets narrow because you're born with a defective valve at birth. For example, the aortic valve, the valve between the left ventricle and the aorta, that gets narrow because the valve structure at birth was bicuspid, means there's 2 cusps rather than 3.
Okay.
So they're defective. So they start narrowing at the age of 50. And after the age of 60, 70, because of the age, there is calcium deposition on even normal valves. And then you get these narrowing at 60s, 70s. So that's most of the reasons why we get narrowing of valves. Of course, you get narrowing of valves at children at birth too.
We have heard about a treatment called Tavi.
Right.
What is it and what kind of valves it cures?
Okay. So Tavi is basically in full form in transcutaneous aortic valve implantation. The gold standard treatment of aortic valve stenosis since a long time has been surgical. That means you send him to a surgeon. Surgeon is going to open the chest, open the heart, and replace this valve with a new valve, which is either metallic or a tissue valve. So the valve actually looks like this even in surgical. This is the Tavi valve, but in the surgery also it looks like that. So why did Tavi come in? Why did the need for putting a valve without surgery came in? So it's happened such that there were patients who were 70s and 80s who had, in addition to heart disease, they had lung diseases, they had liver diseases, they had bad general condition, and the surgeons would say, I'm not going to touch this patient because if I operate him, his risk of dying is very high. So such patients were left to be, so that it was signed that your fate is sealed. We can't do surgery and medicine is not an option. So in early 90s, the scientists said, why don't we try valves that can go in without surgery? Then the research started. So the first valve replacement happened in the year 2002, where a French doctor implanted the valve from the groin is here. He went across into the heart and put a valve with a balloon in the aortic position. And that patient survived long enough. So that started this exploration or explosion of this Tavi therapy. And doctors and patients started realizing that there could be options that can save their lives, which otherwise was not possible.
Yeah.
And this has now progressed to such an extent. So as of 2023, which we are in now, we can also do these procedures in patients who are not high risk or who can't be operated. So now we are providing an alternative to surgery, even to patients who can undergo surgery. So that's the evolution of this valve process that is happening.
So what are the benefits of undertaking a non-surgical procedure compared to the surgical procedures, the traditional procedures?
Okay. Let me ask you a question. If I give you a choice to have a scar or not to have a scar, what would you want?
I wouldn't want to have any scars.
Absolutely. So one thing is surgery leaves a scar. But again, we should not get scared of scars. I feel that if it's necessary, surgery should be done. But if we can provide an equally good alternative which lasts equally long like surgery and gives you a treatment where the suffering is less, the staying is less, you do not need anesthesia for the surgery. So the risk of anesthesia has gone away. And at the same time, you walk out of the hospital in a day and you're back to work within a week, which could never happen with surgery. So why would anybody not want to choose this? So at the present moment, Tavi is a very good alternative to surgery. I'm not saying it's going to replace surgery. There are some patients where we also say, you don't do Tavi, do surgery. But I'm sure that these procedures are now going to be the future of our therapeutic approach.
So Dr. Much has been spoken about aortic valve.
Right.
For mitral, can the same kind of procedures be applied?
Yeah. So mitral actually is the area of research because mitral valve disease is going to far exceed aortic valve disease and already it does. So we need more mitral valve replacements than aortic valve replacements, more mitral valve repairs than any of the valves required, and we want to do this without surgery.
Doctor, please, if you can show it with the
So
model.
what happens, if you see, that's the mitral valve.
Yes.
So it looks more difficult than this rounded aortic valve. So these valves are more difficult to design to fit this area, and this area keeps changing if the heart is big or the heart is small, or if it is leaking or it is narrowed. So mitral valve therapy is in the pipeline, it is being researched, and that is going to be the future. So where are we in the mitral space today? That's the important question. So I'm going to keep this model down and tell you where are we in the mitral space today. So one, if a surgeon has replaced a mitral valve in the past, which is a tissue valve, and if it degenerates, as I told you, it lasts 10 to 15 years, we can replace this mitral valve without opening his chest, the same route as we did the Tavi. Now, why do we need to do this and not do redo surgery? If we do redo surgery, any redo cardiac surgery carries a higher mortality, and I mean mortality, the chance of dying, and more time to recover. So we have a great option that we can replace these valves without surgery. So in a previously implanted surgical valve, TMVR is already there. We are doing it.
Also tell us about TMVR, how this procedure is done and what it is.
So TMVR, as I told you, one is you can only do in a surgical valve. Again, we go the same way, right to left, but this is the valve we take from here to here and place it here. But that is if there's a previous surgically implanted valve. Now research is going on where they're going to put this new valve directly on the native valve. So there's no previous valve. In that there are different routes. One is going to be same, right to left. Go right to left, put a new valve here as you put the aortic valve, or you can go from transapical, which goes from the chest here. Make a very small hole in the chest and go in. and replace this valve. So a lot of research is going on this, and I'm telling you, in the next 2-3 years, it's going to revolutionize the field of TMVR. So we are there with TMVR space now.
It's fascinating, doctor, how you are maintaining the heart health even without surgeries. But what is the benefit of getting the non-surgical procedures compared to the surgical procedures?
Right. Now that's a very important question. So when I'm going to give this option to a patient, I'm going to do this without surgery for you, what benefit am I going to give him? First benefit is, especially if you're a high risk patient for surgery. So if I tell a patient that your risk of getting into trouble with surgery is 10 to 15%, that means 15 out of 100 patients would get into trouble and have a risk of dying. And I offer him a procedure which gives you a 1% chance of dying or a 2% chance of dying. So obviously he's going to choose a procedure which has a less risk of dying.
Yes.
So that's where we are with the transcutaneous space. But that's not the only plus side. The plus side to this is that we do this under local anesthesia. So the patient is not under a ventilator, he's not kept in the ICU with a ventilator. We do it awake, talking to the patient. So as you and I speak, the patient and I speak to each other. And as we speak, we finish the valve. Yeah,
and the patient does not feel any kind of pain since you are inserting the...
Right. So how do we eliminate the pain?
Yes.
So we go from the groin, as you know, which are these arteries in the groin. We give good local anesthesia there, which is called a femoral block. So when we insert these big catheters or needles inside, he does not feel it because he's been numbed completely in that area. And if he's still anxious, our cardiac anesthetist give them a small dose of sedation. So he's awake, but slightly in a good zone, sleepy, he feels nice. So he is awake, but still sleepy, and we save him all the problems of anesthesia. And third, we can discharge him in a day, which is impossible with the surgery. So that's the other major procedure and the advantage.
Are there any precautions that the patients have to be aware of or take when they are going through such procedures?
Yeah. So important thing is, before any procedure, you have to counsel your patient well. He needs to know what to expect. So we tell them all about the procedure, how long the valve will last, what does he need to do to help us for the valve to last. The general thing is, most of the time they don't need to do anything, but they need to take medicines prescribed by us, which are generally blood thinners. They're mild blood thinners like aspirin or clopidogrel. We very rarely give strong blood thinners, which we give in surgical valves, which are called oral anticoagulants, that we give only in patients with rhythm problems. But we need compliance. The patient has to be compliant with what we say. So if I tell him you need to repeat echo every 3 months, see me every 3 months, so he needs to come and see us. In that way, we can progress and see what's happening with the valve, how is heart reacting to the valve. So good compliant patient is generally what we need, and they need to follow what we say.
And how long does it take for a patient to get back to their regular life, to their work, workout routines, family functions?
Right. Okay. So the procedure per se takes anywhere from 30 minutes to 2 hours the day we do it. We generally admit the patient same morning. We tend to discharge them the second evening or maybe the third day at the most. And we tell them to rest at home. Actually, it's not necessary, but it's just a little bit cautious. In a week, we let them come and visit us once. Then they go back to work slowly in a week. And I think in a fortnight, they would be ready to go back to work and party.
Yeah.
But probably gym, exercise would depend on how he evolves. But I think most of these patients are old, so they hardly would be in the gym. But if they need to go, we can guide them and put them through cardiac rehabilitation and get them going. I don't think it's much of a problem.
Wow, it's fascinating that within a week you can recover from a heart disease.
Absolutely.
Even after a procedure when it is done. As we know, everything that we do also has a flip side. Aren't there any flip sides for these procedures?
Okay. So these procedures were designed because surgeons were not willing to operate, right? So it did not start as a treatment for valve disease. It started as an alternative. So the process is evolving. The valves are getting better, the techniques are getting better, the procedures are getting better. But yes, each procedure is a flip side. But compared to surgery, the flip sides are much less. The flip side with this procedure is that some of them we may reject and say you're not fit for this procedure. You have to undergo surgery. And that can be a flip side for a patient, although it may be not a flip side for us. But for a patient, he may go back feeling, oh no, I can't do this. I didn't want surgery.
What other valve diseases can be treated non-surgically?
You mean besides the aortic and the mitral? So right now we are approaching all valves without surgery. Pulmonary valve has been done for quite some time now. We replaced pulmonary valves in children, and the failed pulmonary valves which have happened because of surgery, we are putting a stent and then putting a valve in them if they leak. So that's already been done, pulmonary valve. And actually the research of aortic valve started with the pulmonary valve. So the pulmonary valve was the first valve that was treated non-surgically, and on the basis of this Tavi came, right? And the last valve, which is the most important valve and the most difficult valve for the surgeon to treat, is the tricuspid valve. This is a tricuspid valve. So it has different size leaflets, absolutely difficult to treat. So even the surgeons are wary of touching that. Now when these valves leak, then that's an issue. So like I spoke about the mitral clip, remember we put a clip here?
Yes.
We can clip this also. That's called a tri-clip. But this is technically more demanding because the echo images you get have to be very good. So that takes a longer time, technically more demanding. So you can do a tri-clip, or if there's a failed surgical tricuspid valve like a mitral valve, you can put a valve into a valve and put another tricuspid valve without surgery. But there are some patients whose this valve leaks. When this valve leaks, can you see it goes to the vein?
Yes.
That goes to the upper part of the body, then goes to the vein that goes to the lower part of the body. What happens with these? When these leak, you will see people with huge abdomens. They have all fluid in the abdomen, which is called ascites, and they develop liver cirrhosis. Mind you, this liver cirrhosis is not due to alcohol. This is because of the leaking valve. And then you have swelling of their feet, and they gain a lot of weight, their face is swollen. And when you send it to a surgeon, he says very high risk for surgery, I'm not going to touch it.
When is it that a patient should know or reach out to a doctor for a valve disease?
That's a very, very good question. Because most of us come late to doctors because we do not know when to go to a doctor. Or many a times these valve diseases are not diagnosed, especially the aortic valve diseases. Because if the doctor has not put a stethoscope on his chest and heard that murmur, a murmur is a sound that a closed valve or a leaking valve makes, which you can hear with your ears, then it is missed. But nowadays with so much of education, like we're doing this show, so this whole idea is to educate the public that when should you see a doctor. So nowadays, 2D echo, you must have heard of 2D echo,
Yes.
It's become very routine, it's done routinely everywhere. So if the patient finds in the echo report written mitral regurgitation, tricuspid regurgitation, mitral stenosis, aortic stenosis, pulmonary valve leaking, anything of that sort which they don't understand, please get to your cardiologist. 8 out of 10, it may be nothing. But 2 out of 10, you will be able to catch it in time. You may either do something about it or tell you to follow up and repeat echo every 6 months, repeat echo every 3 months. So anything you do not understand in your echo report, talk to your doctor. That's one aspect. Second is if you have symptoms. Unfortunately, heart and lung symptoms go together. So many of these patients have been experiencing shortness of breath for a long time. And they keep attributing it to asthma. कि बचपन में किसने कह दिया आपको कि आपको दम की बीमारी है, तो उनको लगता है कि अभी भी दम की बीमारी चल रही है. नहीं, अगर है भी, meet a doctor, let him diagnose he is it asthma. With asthma are 2 types. One is to the lung, which is called bronchial asthma, and which is due to the heart, it's called cardiac asthma. And they're both the same. So let the doctor decide कि आपका जो दम है वो कहाँ से आ रहा है. Second is very commonly हम थक जाते हैं और हम उसको इग्नोर करते हैं कि शायद ज़्यादा कम कर लिए. बट अगर ये आपका थकना रोज़ाना हो रहा है जो पहले नहीं हो रहा था, इसका मतलब है कि आपकी बॉडी में ब्लड कम जा रहा है कहीं से. दैट मीन्स या तो आपका वाल्व लीक हो रहा है इसलिए बॉडी को ब्लड नहीं मिल रहा क्योंकि वो पीछे जा रहा है, या नैरोइंग है जिसकी वजह से वो फ्लो को इम्पीड कर रहा है, रोक रहा है और आपको दम लग रहा है बिकॉज आपके पास ब्लड सप्लाई इनफ नहीं है टू बी बीइंग देयर। एंड थर्ड इज चेस्ट पेन, चलने में, बैठे बैठे यू कांट एक्सप्लेन कि ये नया हो रहा है। जो भी सिम्टम्स समझना है ना, डॉक्टर को मिल लिया करो। और धड़कन, दिल की धड़कन बनना, यंग एज में अलग कारण होता है, ओल्ड एज में अलग कारण होता है, तो दिल की धड़कन पे भी ध्यान रखना बहुत जरूरी होता है। सो दीज आर फ्यू रीजंस एंड साइंस सिम्टम्स टू नो कि आपको डॉक्टर को मिलना है, फिर वहाँ से वो डायग्नोस कर लेगा कि क्या हो रहा है। बट ये एपिसोड जो मैं हम कर रहे हैं शुड नॉट बी ओनली फॉर पेशेंट, क्योंकि डॉक्टर को भी अवेयर होना चाहिए कि वाल्व की नॉन सर्जिकल थेरेपी अवेलेबल है। अभी इंफॉर्मेशन इंडिया में इतनी स्प्रेड नहीं हुई, इट इज इंक्रीजिंग बट आई थिंक इट शुड इंक्रीज मोर, कि आपको अपना चॉइसेस पता होना चाहिए, आपको अपने ऑप्शन पता होने चाहिए कि मेरे लिए क्या अच्छा है, क्या बेटर होगा।
सर अगर इन प्रोसीजर्स के बाद भी ये सिम्टम्स परसिस्ट करते हैं तो क्या करें? जैसे किसी ने सर्जरी करा ली है, नॉन सर्जिकल प्रोसीजर कराया, उसके बाद भी अगर कुछ समय बाद उनको जल्दी से थकान हो रही है या सांस में तकलीफ हो रही है तो क्या करना चाहिए?
राइट, अभी ये बहुत अच्छा सवाल है कि मैंने करा लिया, आपने कहा कि दम लग रहा है, मैंने तो प्रोसीजर करा लिया, दम तो बंद ही नहीं हुआ। अभी जो भी प्रोसीजर होता है उसके पहले आपको डॉक्टर को समझ लेना चाहिए कि दम कहाँ से आ रहा है, क्योंकि मैनी टाइम्स हम जल्दबाजी में कोई प्रोसीजर करा लेते हैं और बाद में पता चलता है कि वो जो दम आ रहा था वो वहाँ से नहीं आ रहा था। तो प्रॉपर इवैल्यूएशन बिफोर प्रोसीजर ये सब प्रिवेंट करेगा, क्योंकि इफ आई एम श्योर कि ये यहाँ से आ रहा है तो वो उसके डालने के बाद वो कम हो जाएगा ऑलमोस्ट ऑलवेज। अगर नहीं हो रहा है या तो आपकी डायग्नोसिस गलत थी या उनका जो हार्ट फंक्शन है, क्योंकि अगर आप लेट आए, अभी आपको अगर सर्जरी 10 साल पहले करनी चाहिए, आप 10 साल के बाद मेरे पास आए, तो आपका हार्ट ऑलरेडी डीकॉम्पेंसेट हो चुका है तो ओवर दिस 10 ईयर्स। तो अगर मैं वाल्व बदली भी कर दूं तो बेनिफिट इतना नहीं होगा जितना होना चाहिए। सो समटाइम्स लेट प्रोसीजर कैन लीड टू persistent of symptoms or not significant reduction of symptoms. And third is very rarely आपका नया वाल्व फिर से चोक हो गया, जल्दी चोक हो गया। जनरली 10 साल लगते हैं बट किसी किसी में जल्दी चोक हो जाता है, या वाल्व में इन्फेक्शन बैठ गई जो हो सकता है, तो ये फिर से जल्दी तकलीफ हो सकती है। बट इसका समाधान आपको डॉक्टर को मिल के ही होगा, ऐसा नहीं होगा। इसलिए डॉक्टर आपको बताते हैं कि डिस्चार्ज के बाद क्या करना है, वो फॉलो करिए। तो फॉर एग्जाम्पल हम जो वाल्व रिप्लेस करते हैं किसी का भी, ये जो डिजीज है डिफेक्टिव वाल्व है, तो आपको डॉक्टर बता देगा कि आप कभी भी सर्जरी के लिए जाओ, एनी सर्जरी, इवन डेंटल प्रोसीजर और नॉन कार्डियक सर्जरी, अपने डॉक्टर को बता देना कि मेरा ये वाल्व बदली हुआ है, तो आपको वो बिफोर एंड एंटीबायोटिक दे देगा। अगर आप एंटीबायोटिक पहले से लेते हैं तो रिस्क ऑफ इन्फेक्शन ऑफ द वाल्व डजंट हैपन। अगर उसको पता नहीं है और उसने आपकी सर्जरी कर दी, तो ड्यूरिंग सर्जरी, एनी सर्जरी, बैक्टीरिया गो इनटू द ब्लड and that bacteria can go and infect the valve. So ये सब you have to discuss with your doctor before you take any major decision.
Are there any specific kind of patients who need cath lab procedures?
So you're trying to ask me which patients will benefit with these procedures.
Yes.
So I think the best one is aortic stenosis, narrowed aortic valve, where Tavi has reached almost near perfection. So these patients, yes, of course, valve in valve, which I spoke, TMVR and all that, mitral clips, tricuspid clips, and pulmonary valves. There are other procedures like hole closures, ASD, VSD, PD. We are not going into that. And there are procedures where the valve leaks on the side. We can go and close them with plugs. So all these, rather most procedures that a surgeon can do can be successfully done in the cath lab. So I don't think that there are going to be procedures which only surgeons can do, but yet there are some. I think over time this line is going to blur further and further. It's already blurring.
Okay. Tell us about the structural heart procedures that you have undertaken.
Yeah. This is important to inform that India is equally advancing like the West, because we had this concept कि ये पहले West में जाना पड़ेगा ये सब procedure. We have done all these procedures which I have spoken to you about. So we have done more than 400 TAVIs, which is a large number. In fact, we go and teach TAVIs to the world. TAVI is this aortic valve replacement. We have done more than about 25 mitral valve and valve replacements. We've done about 3 to 4 mitra clips. We have done the first or the second tricuspid valve in the country. We've done hole closures, we have done closures of leaks. So all this has been already done by us, our team at SL Raheja Fortis Hospital. And I can assure all of you that once you come to us, you're going to be safe and get the right advice for your diseases.
Doctor, when a patient is coming for a procedure, for a cath lab procedure,
Right.
what is it that the patient should expect?
Yes. So patients should be educated about what is going to be his day like and what is going to be his stay like. So pre-procedure, we prepare them by doing some blood tests to assess the safety of the procedure for him. We tell him the importance of the blood test. He has to come fasting on the day of the procedure. We do the procedure for at least 6 hours fasting. So we need 6 hours fasting. During the procedure, we explain to him that he's going to feel pinprick when we give him the anesthesia. So he feels that. And we tell him he's going to feel a little woozy or sleepy because we're going to give him some sedation. But at the same time, he's awake, he can speak to us. Post the procedure, he will be in ICU for a day. That's very important because most patients don't like ICUs. I understand why they don't, but they have to be in ICU for monitoring for a day. So we inform him about that. He may get or may not get some pain in the groin area where we have put the catheter. But generally it doesn't pain, but if it pains, we can take care of it. We also inform him in case he notices blood coming out. He should inform the doctor immediately so we can take care of it. But it generally doesn't happen because we fix all of that before he leaves the cath lab. So next day of the procedure in the morning, we try to mobilize him, move him around in the ICU. If he's good to move around, we shift him to the room with his family. He can eat, he can drink, he can walk. We give him the medicines, the antibiotics, he has to take them. And by evening or next day, we send him home with clear instructions that any untoward incident which you think is not your normal happens, let us know. So if you feel dizzy or you feel woozy or you feel that you see blood going from the area of where it has been done or you feel fever or anything like that, get back to us immediately. All these things rarely happen, but this is what we tell them. And then we call them at 7 days for a follow-up and take care of it. But generally, it's a simple in-out procedure.
Wonderful, doctor. Thank you so much for your time and for giving us this invaluable knowledge. I know you have to go and perform a Tavi procedure now, so will not take much of your time, but really appreciate your presence.
Thank you very much.